Hello friends, so we would discuss a new topic, opioid in anesthesia. Now, role of opioid in anesthesia is mostly as an adjuvant to the main anesthetic agent and as providing for analgesia, as an analgesic agent. So opioid is rarely used as the main sole anesthetic agent during general anesthesia. So its role is mostly as an adjuvant or an analgesic agent. Okay, it's an important drug which we are using during anesthesia. So few things we have to discuss about opioid, few drugs we have to discuss about opioid. All the drugs which I will discuss in opioid in anesthesia are mostly the drugs which we are using very commonly during anesthesia. I wouldn't cover all the drugs. It is not required to know about every drug. There are so many drugs present in opioids, right? So I would only focus on the drugs which we are very commonly using in anesthesia. Now, the role of opioid as for anesthesia dates back very primitive, very old. It has a very old, let's say it is being used for anesthesia even before proper anesthesia was described. So even before the description of proper anesthesia, opioid was used here and there for doing various superficial surgeries, right? So it has a very old history, right? And morphine is the prototype drug, a natural opioid which we are using, right, during anesthesia. And our let's say explanation would be focused around morphine. I will discuss morphine in detail and I will focus the explanation of other drugs around comparing it with morphine so that it would be easier to remember and solve the questions during exam. Now, opioid, right, opium, Morpheus, these all are the old words for the opioids, right? Morpheus means God. Morpheus is god of dream. So Morpheus is god of dream. Opioids produce a dreamlike sensation. So with Morpheus, the god of dream, the word morphine was originated. The word morphine was originated. And opium, the original word of opioid, means nectar, right? So these are just few historical aspects of the word opioid and word morphine. Now, how is opioid classified? The classification of opioid is done in two ways. The first classification is done from their source, how we get the opioids. So first classification of opioid is according to source. Natural opioid, semi-synthetic opioid, and purely synthetic opioid. Natural, which we get from the opium plant, morphine, codeine, etc. Semi-synthetic, which are derivatives of the natural opioids, and synthetics, which are absolutely produced in laboratory. They have no source from the natural opioids. So this is according to the source, not much asked in exam. Now, classification of opioid done on the action of opioid on various receptors are more important classification. Agonist or antagonist on various receptors, opioid receptors. We all know that there are three main opioid receptor, mu, which is mu1 and mu2, and kappa and the delta receptors. Kappa and delta receptors. Now, opioids are either pure agonist on these receptors, they have a full action on these receptors, or partial agonist, or agonist antagonist, that is agonist on a receptor and antagonist on some other receptor, and pure antagonist on all the receptors. So classification, this is the more important classification. Classification based on action on receptors. Number 1, pure agonist, which has 100% action on the receptors, pure agonist. These are the most important opioid which we are using during anesthesia. And what comes in pure agonist? Morphine, fentanyl, alfentanyl, sufentanil, and remifentanil. Right? These are pure agonists with 100% action on the receptors. Then we have partial agonist, which has not 100% action. They have less than 100% action on the receptors. And the most important drug which you have to remember this in is buprenorphine. Buprenorphine, a very important opioid, partial agonist opioid. I have discussed buprenorphine in this subsequent lecture. Then we have agonist, antagonist. Agonist and antagonist. So these drugs are simultaneously agonist on mu receptor and antagonist on other receptor. Mostly they are antagonist on mu receptor and agonist on kappa and delta receptor. So there are 3 drugs which we have to remember in this: pentazocine, nalbuphine, and buterphenol. So pentazocine, nalbuphine, and buterphenol are agonist, antagonist. Mostly antagonist on mu receptor and agonist on kappa and delta receptor. 4th, pure antagonist. 3 important drug: naloxone, naltrexone, and nalmefene. Naloxone, naltrexone, and nalmefene. These are pure antagonist. 3 drugs which are pure antagonist on all the 3 receptors, opioid receptors. So guys, this is very important. They ask this question: pure agonist opioids, partial agonist opioid. All opioids are agonist, antagonist except. And which of the following are pure antagonist on opioid receptors? So naloxone, naltrexone, and nalmefene. Nalbuphine also has nal, but it is not a pure antagonist. It is agonist, antagonist. Remember, buprenorphine is not a pure agonist. It is a partial agonist, right? It doesn't have 100% action. It has less than 100% action on the receptors. So to remember agonist, antagonist, P and B, that is pentazocine, nalbuphine, buterphenol. B, buterphenol is agonist, antagonist, and buprenorphine is partial agonist. So clearly you have to remember these things. Which are the questions which can be asked on classification of the opioid, right? So this is how we classify the opioid. Now I will start my discussion of opioid with the prototype drug, the natural opioid, that is morphine. So guys, we will purely talk about the pure agonist, the role of pure agonist in anesthesia. Now these are of main interest to us, to anesthetists. Why? They are used along with inhalational and IV anesthetic agents as adjuvant. So what is the primary role? I told opioids are primarily used for analgesia. So they are used with inhaled and intravenous anesthetic agent. As adjuvant to provide to contribute in analgesia and sedation. Okay, large doses, now important statement. Now the next statement is very important. Large doses of these opioid, large doses of morphine, fentanyl, sufentanil, even the latest one, remifentanil, has been used as sole anesthetic in critically ill patient, in critically ill patients with cardiovascular compromise. Critically ill patient with cardiovascular compromise. Okay. So, we are using large doses of morphine, fentanyl, sufentanil, remifentanil as sole anesthetic agent, alone anesthetic agent in critically ill patient with cardiovascular compromise. Now, very important. We are mostly using opioids as analgesic. Only in critically ill patient with cardiovascular compromise, we are using it as sole anesthetic agent. Why? Because opioids, even in a very high dose, are cardiovascular stable. We will discuss about the cardiovascular stability of opioid. Okay. Now, let us discuss the prototype drug morphine and let us compare all the other drugs with the prototype drug. So, coming on morphine. Morphine. What does morphine do? It produces analgesia, euphoria, and sedation. Right? It is acting on mu kappa receptors, mu kappa and delta receptors, right? And it is producing analgesia, euphoria, and sedation. Now, how do I give morphine? What are the routes by which I can give morphine to my patients? So, what are the routes of administration of this drug? Now, this is again a very popular question of opioids, that how do you give them? So, morphine can be given intravenous. I can give it IV. I can give morphine intramuscular. I can give morphine even oral. Oral tablets of the morphine is also given. Oral supplements of morphine are there. IM also we are injecting, IV we are also injecting. And we are also using morphine in the epidural space. We are using morphine for epidural analgesia also. So, we are using it in neuraxial, epidural, or we call it neuraxial route. Neuraxial route. This morphine, coming on its pharmacokinetics. Pharmacokinetics. This morphine is hydrophilic. Hydrophilic. It doesn't have a very good penetration in brain. Then how does it act? And why it doesn't have a very good penetration in the brain? Why it has a poor penetration in the brain? Why it has a slow onset of action? See, to produce the anesthetic effect, it has to act on CNS. But morphine is not a very good drug because of poor penetration, it has a slow onset of action. So, coming on why it has a poor penetration. What is the problem with morphine? Penetration in the brain, right, into CNS. What are the reasons? There are few reasons. Number one, as it's hydrophilic, poor lipid solubility. Poor lipid solubility. Then, high degree of ionization. If the drug is highly ionized, it will not penetrate the brain. Later on, the later opioids which we will discuss, they are mostly in unionized states. Like for example, I will discuss alfentanil. It is mostly in unionized state. So, it has a very fast CNS penetration. So, this morphine, highly ionized. Highly ionized, high degree of ionization. Then, protein binding. because of protein binding, huge protein binding, again poor penetration to CNS, and it is rapidly conjugated to glucuronic acid. So because of these four factors, it has poor penetration to CNS. It has a poor lipid solubility, highly ionized. We need unionized drug to pass the blood-brain barrier. It has a huge protein binding, and it is rapidly conjugated to glucuronic acid. These are big molecule. If it will not remain alone, it will not penetrate the blood-brain barrier. So because of these factors, it has a slow onset. It is not as fast as other opioids, which we will discuss after morphine. So it has a slow onset. Now coming on its metabolism. Now remember guys, metabolism of most of the opioids are through liver metabolism. They are mostly dependent upon liver for their metabolism. Okay. So in liver, what happens? Morphine interacts with glucuronic acid, that is, morphine is rapidly conjugated, and it produces as a metabolic byproduct two main byproduct. One is morphine 3 gluconides, and other is morphine 6 gluconides, right? These are the two byproducts, the main byproducts. 70 to 80% is morphine 3 gluconides, and 10 to 20% is morphine 6. Rest little bit of codeine is also produced as a byproduct, which are of not much importance. These are the two main byproducts. Of this, morphine 3, which is the major byproduct, doesn't have any effect of morphine, doesn't have any like agonist effect on the opioid receptor. So it is inactive let's say inactive metabolite. But morphine 6 gluconides, this though produced in lesser amount is a active byproduct with agonist action on the opioid receptors, and it is completely excreted through kidney. This is excreted through kidney. So in case of renal failure, renal impairment, this compound can accumulate and can prolong the effect of morphine. Even though morphine is metabolized as the byproduct of morphine 6 gluconides, which is present in 10 to 20%, right? Morphine is metabolized to morphine 6 gluconides in 10 to 20% concentration. It is an active byproduct. If it accumulates, it is not excreted through kidney, then the effect of morphine gets prolonged through this active byproduct of morphine. Okay. Now coming on the effect of morphine on different organ system. Effect of morphine on different organ system. Right. Let us start with our most important organ of interest, cardiovascular system. See, here I am not going in the sequence of central nervous system and the cardiovascular system, because with opioid, our major interest organ is cardiovascular system. The positive effect of opioid is on cardiovascular system. So what is the effect of opioid on cardiovascular system? You know, morphine, the analgesic dose is 0.1 milligram per kg body weight. But even if I give a very large dose, I give 1 to 2 milligram per kg body weight, then also in a supine, that is supine normovolumic patient, morphine has no effect on cardiovascular system. So administration of large dose also of morphine, normal dose no effect, even large dose of morphine does not cause any myocardial depression or hypotension, does not cause any myocardial depression or hypotension. So this is the benefit of this opioids. Even high dose is producing no cardiovascular compromise. So as we wrote, in critically ill patient with cardiovascular compromise, this could be used as a sole anesthetic agent, right? Now what's the problem of using it as a sole anesthetic agent? I will tell you, okay? But let's say if I give morphine to a, let's say not to a supine patient, rather if I give morphine to a patient who erect patient, walking patient, then what effect it can have? Little bit morphine can cause decreases systemic vascular resistance, little decrease in systemic vascular resistance in erect patients, and little bit decrease the blood pressure. Little bit decreases the blood pressure. Not significant, but little decrease in blood pressure can happen. Okay. Now, little bit morphine can cause bradycardia also. It has a bit inhibitory effect on SA node. So, may cause, I'm writing may cause bradycardia. Bradycardia also, right? So, otherwise morphine is cardiovascular stable. In an erect person, it can decrease systemic vascular resistance and little bit hypotension can happen. And it may cause bradycardia. If any cardiovascular compromise it causes, little bit bradycardia is reported with morphine. Okay. Now coming on, I told I can use large dose of morphine in critically ill patient. But what is the problem? Problem is effect on respiratory system. Respiratory system. Guys, morphine has dose dependent depression effect on ventilation. Dose dependent and gender specific, more in female, and gender specific depression of ventilation. So, how does it do that? By 2-3 effects. Number 1, direct depression of ventilatory center of brainstem, right? Then, second, inhibits the respiratory response to carbon dioxide. Inhibits the respiratory response to carbon dioxide. Okay. So even if PaCO2 increases, the respiratory center is not stimulated. Okay. Then it also interferes with pontine. Apart from brainstem, the main respiratory center present in brainstem, it also have an effect on pontine and medullary ventilatory center. Pontine and medullary ventilatory center, right? And increases the pauses between the breath, and increases the pause between breaths, right? The pattern of breathing which it produces is pontine breathing with increased pause between the breath. That is a periodic breathing kind of thing, right? That is periodic breathing produces. So morphine, apart from brainstem respiratory center, the main respiratory center, also interferes with pontine and medullary ventilatory center and increases the pause between the breaths, produces a periodic breathing. produces periodic breathing, right? This morphine induced depression of respiration lasts for long hours, has a prolonged effect on the ventilatory center. So it has prolonged effect on ventilatory center, right? And the respiratory depressant effect of morphine is more seen in three subpopulation, more in old, neonates and females, right? It is seen more in old patients, neonates and females. So they are more sensitive to morphine induced respiratory depression. Okay? Then morphine decreases the ciliary activity of the respiratory tract. So it decreases ciliary activity of respiratory tract. Okay. Morphine has a direct depressant effect on cuff centers. The cuff center present in medullary cuff center, morphine has a direct depression on that particular center. So it has a very good antitussive role. So it has a cuff suppression effect. Cuff suppression effect on medullary cuff center, medullary cuff center. Okay, so it has a very good antitussive effect, antitussive effect. Okay, so this is the effect of morphine on respiratory system. So if I put a patient on a high dose of opioid for anesthesia, the respiratory center is depressed for a prolonged period of time. So I'll have to keep my patient after reversal or ventilator. And gradually, when the effect of opioids on the respiratory center will wean off, then I can reverse my patient, right? So we have to support the ventilation. Okay. Now what is the effect of opioid on CNS, central nervous system? Well, mostly like non-opioid IV anesthetic agent, they decrease cerebral metabolic oxygen requirement, that is CMR O2, decreases cerebral blood flow coupler. We discussed if CMRO2 is reduced, cerebral blood flow should reduced. We have already discussed this in the video of inhalational agent, that this is called CNS coupling. So if CMRO2 is reduced, cerebral blood flow would reduce, and definitely ICP will decrease. ICP will decrease, right? The EEG, changes in the EEG would be same as a non-opioid IV anesthetic agent, that is from high amplitude to low amplitude. That is, it will go towards the sleep waveform. So EEG will go from beta to alpha to theta to delta. That is like any other anesthetic agent, which would decrease the activity of brain. Same is the effect of opioid. Now, there are few opioids with few unique effects on CNS, which can be asked in the question, which we have to focus on, right? Now, there is a very important effect of opioid, that is skeletal muscle rigidity. Skeletal muscle rigidity. Now, how is this skeletal muscle rigidity happening? Any skeletal muscle, abdominal, thoracic muscle, any muscle rigidity can happen. Now, very popularly it is called fentanyl-induced chest wall rigidity. very commonly seen with fentanyl. So more popularly it is called fentanyl-induced chest wall rigidity. So even abdominal wall rigidity, any skeletal muscle rigidity can happen. So chest wall rigidity, abdominal wall rigidity, anything can happen. Now why is this happening? This is happening because opioids inhibits the release of strial gamma aminobutyric acid, GABA neurotransmitter, and increases the release of serotonergic neurotransmitter. So what happens? Imbalance between GABA and serotonin causes this chest wall rigidity, abdominal wall rigidity, that is skeletal muscle rigidity. How does it happen? This is happening because of inhibition mechanism. What is the mechanism of this rigidity caused by the opioids? That is inhibition of striated muscle release, strial release of gamma aminobutyric acid, that is the inhibitory neurotransmitter, and increased release of dopamine. Okay, because of this imbalance, the skeletal muscle rigidity happens. This is more commonly seen in, this is in bracket I am writing, it can be seen in morphine also, but more commonly seen in fentanyl. Guys, popular fentanyl-induced chest wall rigidity. The popular word fentanyl-induced chest wall rigidity. Well, when this happens, the ventilation also becomes very difficult. Right? This happens more commonly when I am giving the dose of opioid very rapidly, very rapid injection of the opioid. Right? So this is what is our rigidity, fentanyl-induced chest wall rigidity, that is skeletal muscle rigidity caused by the opioids. Then some opioids can show myoclonic activity. So myoclonus, that is tonic-clonic seizures. Clonic, sometimes tonic seizures, right, has been reported. Myoclonus has been reported. Again, more commonly with fentanyl than morphine, right? Okay. Now guys, morphine produces meiosis. How morphine is producing meiosis? By having a excitatory action of morphine on autonomic nervous system component of Edinger-Westphal nucleus, right? Edinger-Westphal nucleus. So by having an effect on the autonomic nervous system component of Edinger-Westphal nucleus, it is producing meiosis, constriction of pupil, right? Now what is the effect of morphine on biliary tract? Popular effect, biliary tract. It causes spasm of biliary tract, of biliary smooth muscle, right? It causes spasm of biliary smooth muscle. Okay. Now what is the effect of morphine on GI tract? GI tract. Now guys, on GI tract, morphine decreases the GI motility and can lead to constipation. Spasm of GI system decreased gastric emptying can lead to constipatory effect of morphine. Right. Now guys, what is the effect of morphine on nausea and vomiting? Nausea and vomiting. Now morphine has a direct stimulant effect on CTZ center. Stimulation of CTZ center. So precipitate nausea and vomiting. So it is highly emetogenic. So morphine is highly emetogenic. Morphine causes nausea and vomiting. It is highly emetogenic. Got my point? So morphine is a drug which is causing high level of nausea, vomiting by a direct effect on CTZ, center. Got my point, everyone? Okay. Now let us say morphine, one important nasty side effect, most common side effect of morphine is pruritus, right? Pruritus. Now, this pruritus caused by morphine, right, is mostly seen around the nose, face, the cutaneous skin of around the nose, face, and upper thorax, right? So this is more commonly seen in face, around nasal cavity, around nose, not a nasal cavity, rather I should say around nose. So pruritus is more commonly seen in face, around nose, and neck and upper chest. Now, why is this localized pruritus? It is not because of histamine released by morphine. Morphine can release histamine, but it is not because of histamine released by morphine. Rather, it is because of stimulation of trigeminal nucleus, right? Because of cranial migration of morphine, it gets absorbed and cranially migrate, right, from spinal cord. And what happens? That it activates trigeminal nucleus. So what is the mechanism of this? Not histamine release. Mechanism is stimulation of trigeminal nucleus. Not histamine release. Not histamine release. Not by histamine release. So a lot of misconception that this pruritus is because of histamine release. No, it's not because of histamine release. Now, if I give overdose of morphine to my patient, how do I diagnose it? What is the typical clinical feature which comes on overdose of morphine? Depression of ventilation. Which manifests, there is a depression of ventilation which is manifested, which decrease in the frequency of the breath. Ultimately, it leads to apnea. So what is the triad of overdose? Triad, right? In overdose, what will happen? Depression of ventilation. Manifesting as a slow breathing can lead to apnea. Now, what is the triad? Triad of morphine overdose. So, what is the triad of morphine overdose? Meiosis, hypoventilation, and coma. Meiosis, hypoventilation, and coma. This is the triad of morphine overdose. Okay, guys. So, this is the triad of morphine overdose. So, morphine is our prototype. Morphine is our prototype drug, right? All the other opioids which I will compare with morphine itself. Okay, so the next opioid which I will discuss, a pure agonist opioid which is of more interest to the anesthetist, is meperidine. Meperidine or pethidine. Pethidine. What is meperidine or pethidine? It is synthetic opioid. Right? It is synthetic opioid, agonist at mu and kappa receptor. Agonist at mu and kappa receptor. Right? It is a phenylpiperidine derivative. Phenylpiperidine derivative. Right? And this meperidine has 4 derivatives which we will discuss in detail: fentanyl, sufentanil, alfentanil and remifentanil. Okay. Now, this pethidine, some important point about this meperidine pethidine. The structure. Its structure has similar groups, similar features, similar group of local anesthetic. Right? So, structure similar to local anesthetic. Right? It has a similar structure to local anesthetic. It has a amine. It has a ester group, amine group, ester group. Right? It has a ester group, lipophilic phenyl group and tertiary amine group. So these ester group, lipophilic phenyl group and tertiary amine group are the common groups which it shares with local anesthetic. These groups are also there in local anesthetic. So this pethidine, right, can also block sodium channel like a local anesthetic, which is a very peculiar property of pethidine. Can block. They asked this question in AIIMS so many times. They have asked local anesthetic property. Which opioid has local anesthetic property? Which opioid has local anesthetic property? Pethidine, right? Meperidine, right? Can block sodium channel. Can block sodium channel to a degree. You won't believe, to a degree comparable to lidocaine. To a degree comparable to lidocaine. And this is the only local anesthetic, only opioid which can be used like a local anesthetic, as a sole local anesthetic instead of adjuvant, right? So since it has lot of groups resembling the groups of local anesthetic, it can block the sodium channel and can be used as a sole local anesthetic. It has been used. It is comparable to the degree of sodium channel blockade of lignocaine, right? And one more thing, a peculiar thing about the property of pethidine is that the structure, it has a lot of groups of local anesthetic and structure is very similar to atropine. So it has a structural similarity. Structural similarity to atropine. So some properties of atropine is also exhibited by pethidine. Okay, now coming on its pharmacokinetic properties. Pharmacokinetic properties. 1/10 the potency of morphine. It is 1/10 the potency of morphine, right? It has 1/10 the potency of morphine. Duration of action. duration of action is 2 to 4 hours. Definitely less than morphine. Morphine has duration of action 3 to 6 hours. It has 2 to 4 hours. Now what are the routes? We can use it IV, we can give it IM, we can give it oral, right? And as local anesthetic, we are using it intrathecal, right? We are giving it in subarachnoid space also, right? Okay. Now, what is the metabolism of this pethidine? Metabolism of this meperidine, pethidine, whatever. Metabolism is like any other opioid in liver, hepatic, right? 90% of the drug undergo demethylation to normeperidine, right? To norpethidine or normeperidine, right? This accumulation, the important thing, this is again, this normeperidine is excreted through kidney. So in any problem, renal dysfunction, this can accumulate. So accumulation of normeperidine can cause CNS stimulation, right? It has a CNS excitatory effect, CNS stimulation. It can lead to myoclonus, seizure. So it can lead to myoclonus, seizures, etc. Okay. What are the clinical use of this meperidine? Clinical use. Most popularly nowadays, previously also, it was used for analgesia during labor and delivery. For painless labor and delivery, right? Analgesia during labor pain, after delivery, and post-op, and after surgery, and after any routine surgery, and after surgery. So for labor pain, for post-surgical pain, post-delivery pain, we are using this meperidine very popularly. One very good effect, very good role of meperidine is, this is the drug of choice for treatment of post-op shivering, right? So it is most effective. I'm writing with red pen. This was asked in AIIMS also. Most effective drug in suppressing post-operative shivering. Now, why it is so good in suppressing shivering? Because of its effect on mu and kappa receptor both. And one more, because of its effect on mu and kappa. And second, because of its effect on as alpha-2 agonist. It is a potent alpha-2 agonist, right? Like dexmedetomidine also. Dexmedetomidine also has role in being an anti-shivering agent. Or this meperidine also has a very good role by being an alpha-2 agonist in shivering as a potent agent for suppression of shivering. So because of its effect on mu and kappa receptor and alpha-2 agonist, it's a very good anti-shivering agent. Okay. Now, what is the effect of this drug on different organ system? Very fast, just comparing it with the morphine. Cardiovascular system, more or less like morphine. Cardiovascular, stable. But in morphine, I told it can cause bradycardia, right? Sometimes, rarely, it can cause bradycardia. This meperidine never causes bradycardia. Rather, since it has structural similarity to atropine, it can cause tachycardia. So, similar to morphine, I am writing, similar to morphine, right, except it can cause tachycardia. It can cause tachycardia. Okay, everyone? Okay. Rest of the things like effect on CNS, effect on respiratory system, respiratory depression, more or less same as morphine. So rest of the properties more or less same on morphine. Only on cardiovascular system, since it has structural similarity to atropine, it can cause tachycardia. Okay. Now one important side effect and caution which we have to take while giving the meperidine is its predisposition to cause something called serotonin syndrome. What is this serotonin syndrome? Guys, there are few drugs which increases the concentration of serotonin in blood and produces this serotonin syndrome, which leads to autonomic instability. Now, autonomic instability with hypertension, tachycardia, the clinical features: hypertension, tachycardia, diaphoresis, hypothermia, right, agitation, right, and hyperreflexia. So it leads to hypertension, tachycardia, diaphoresis, hypothermia, agitation, hyperreflexia. When this pethidine can lead to this serotonin syndrome, when we are giving pethidine and patient is already being given some let's say depressant drugs like MAO inhibitors, right? MAO inhibitors, fluoxetine, etc. They interact. MAO inhibitors and fluoxetine and pethidine interacts and increases the serotonin in blood. So this happens when it is given with other drugs capable of increasing the level of serotonin. Right? So like MAO inhibitors and fluoxetine. Okay, this is serotonin syndrome, which can be seen with meperidine. Okay, now guys, morphine produces meiosis, right? But since meperidine has a structural similarity to atropine, it doesn't produce meiosis, rather it produces mydriasis. So it can cause mydriasis. Instead of meiosis, it can cause mydriasis, right? So it can cause mydriasis. Okay, so this is one other unique property of pethidine. So this is all about pethidine I wanted to talk. Now coming on the derivatives of pethidine. The first and the most important derivative, and in India the most commonly used derivative of pethidine, is fentanyl. Fentanyl. Now what is fentanyl? It is phenyl derivative of pethidine, right? A potent opioid agonist, very potent, 75 to 100 times more than morphine. It is 75 to 100 times more than morphine. Its potency is very, very high. So why this drug has such a high potency? I'll discuss about it because of its high lipid solubility. Now, the pharmacokinetic. Of this drug. IV injection causes rapid onset. causes rapid onset, right, and has short duration effect. So when I give this fentanyl intravenously, it has to achieve a concentration in brain, effect site equilibrium. It has to reach an equilibrium in between CNS and blood, effect site equilibrium. It takes 6.8 minutes to achieve that. So effect site equilibration time is 6.8 seconds for morphine. So it reaches an equilibrium between brain and blood in 6.8 to 6.8 seconds, right? Why it is so fast, right? Because number one, high lipid solubility. It is very lipid soluble agent, right? High lipid solubility. Now how it is metabolized? Metabolism, similarly like any other opioid, hepatic metabolism, like any other opioid, hepatic metabolism, right, to norfentanyl. Okay. Now what are the uses of this fentanyl? Now uses are according to the dose. Let us start with the lowest dose. The lowest dose for analgesia. The dose is 1 to 2 microgram per kg intravenously, IV. Second, adds adjuvant along with other anesthetic agent. Adjuvant for anesthesia. Not as a sole anesthetic agent, but as adjuvant for anesthesia. It is, the dose is 2 to 20 microgram per kg IV. Okay, with other anesthetic agents. Okay, and guys, very large dose, very large dose, that is 50 to 150 microgram per kg IV for surgical anesthesia plane, to produce surgical anesthesia alone. Surgical anesthesia, not with any other agent, alone, the dose is very high. It is 50 to 150 microgram per kg body weight. Now, if I am using fentanyl in such a high dose, is it causing any problem on cardiovascular system? No. That is the benefit of opioids. Again, I am repeating the same thing. So if I am using opioid, fentanyl, for surgical anesthesia, what are the advantages? Lack of direct effect on myocardium. No effect on myocardium. Better than morphine in being no histamine releaser. Absence of histamine release. And another beautiful response of fentanyl, suppression of stress response, sympatholytic. It has a sympatholytic effect. So suppression of stress response. So good. But what is the problem? As I already told, prolonged depression of respiration. So what's the disadvantage? Disadvantage is prolonged depression of respiration. Okay, prolonged depression of respiration. Now guys, the other use, fourth use, intrathecal. We are using it along with a local anesthetic, right? It is also a pethidine derivative, so it also has a little local anesthetic properties. We are using it along with local anesthetic for spinal anesthesia. So intrathecal use. For intrathecal use, we have a ceiling effect of fentanyl. Beyond certain dose, it will have no effect. So what is the maximum dose of fentanyl used for intrathecal use? 25 microgram. So maximum dose for intrathecal use, maximum dose is 25 microgram, 25 microgram, right? Maximum, not according to body weight, maximum 25 microgram. Okay. Now fifth use, transmucosal preparation. Okay, transmucosal preparation like fentanyl lollipops, oral fentanyl lollipops, right? We have oral transmucosal preparation, right, of fentanyl. But the problem of this is they are associated with very high degree of nausea and vomiting and sedation. So problem is of transmucosal preparation is association of sedation and nausea and vomiting. Association of sedation and nausea and vomiting. Now the transmucosal dose of your fentanyl, transmucosal dose of fentanyl is 2 to 20 microgram per kg body weight. Okay, guys, then we have fentanyl patches available. We have fentanyl patch. Fentanyl patch is applied after cleaning the skin surface, and per hour release of fentanyl from this fentanyl patch is 75 to 100 microgram. Now peak effect of fentanyl after applying fentanyl patch is after 18 hours. So peak effect is at 18 hours. And even when we remove the fentanyl patch, there is a prolonged analgesic effect of fentanyl because of the deposition of fentanyl in skin depots and slowly release from skin depot into the blood. So drug gets accumulated in skin depots, right, in skin depots. Okay, and slowly released. They are slowly released. So drug gets deposited in skin depots and are slowly released. So that's the benefit of fentanyl patch. We have a prolonged effect. The peak effect reaches at 18 hours and drug is slowly released even when the fentanyl patch is removed. So these are the uses of fentanyl. The next drug which I will discuss, another derivative, sufentanil. Just few lines, just difference of sufentanil from fentanyl. It is a thionyl analog of fentanyl. It is 5 to 10 times more potent than fentanyl. So it is even more potent than fentanyl. 5 to 10 times more potent than fentanyl. So fentanyl is 75 to 100 times more potent than morphine. Sufentanil is 5 to 10 times more potent than fentanyl. So it's a highly potent drug. Okay. Why it has such a high potency? Like fentanyl, it is also lipid soluble, but more potent than fentanyl because it has a high affinity for opioid receptor. Higher affinity for opioid receptor. Okay. Now guys, one difference, a benefit rather, of sufentanil over fentanyl. I told you when I was discussing morphine that myoclonic activities etc. can be seen with opioids, right? It is seen with fentanyl also, right? This myoclonic activity is not seen with sufentanil. That's the benefit of this drug. So, one benefit over other opioids, less or no myoclonic activity, myoclonic side effect. Okay. The onset, the pharmacokinetic properties. Pharmacokinetic property. Faster onset than fentanyl. Effect site equilibration of sufentanil, faster onset than fentanyl. This has a faster onset. So effect time equilibration is 6.2 minute. Fentanyl had 6.8, it has 6.2 minute, right? So again it is highly lipid soluble, so it has a faster onset. So short duration, it has a duration is shorter. Why? Because of rapid redistribution. So it has a short duration leading to rapid, because of rapid redistribution. It gets redistributed to the other tissues, rapid redistribution. So that's why the duration of action is shorter after the single dose, right? High protein binding. Another property of this is like any other fentanyl derivatives, highly protein binding. Metabolism again is by liver and dealkalization. Okay. So what's the clinical use of this drug? Guys, from sufentanil onwards, we are not using it in intrathecal space. Pethidine was used, that is meperidine was used, fentanyl was used. But sufentanil, alfentanil and remifentanil are not used. So clinical use is only analgesia and in a very high dose anesthesia. Analgesia and in a very high dose for anesthesia. So like other opioids, we can use it for analgesia and we are using it for anesthesia, right? Anesthesia. Okay. So this is all about our sufentanil. The other derivative is alfentanil. Just few lines. The difference actually. Alfentanil, little bit potency is less, right? Alfentanil. Now, it is again an analog of fentanyl, which is 1/5 to 1/10 times less potent. 1/5 to 1/10 times less potent. What is the advantage of this drug? That's more important. Advantage is very fast effect site equilibration. Guys, alfentanil reaches the brain, achieves an equilibration between brain and blood in a very short period of time of 1.4 minutes, right? So very rapid action. Advantage, rapid action. Effect site equilibration 1.4 minute. Very fast. Fentanyl was 6.8 minute. Sufentanil was 6.4 minute. and this is 1.4 minute, very fast, right? And the other advantage is that faster elimination also. Faster. The other advantages, other benefit, faster elimination. It goes out of the body also fast, right? So rapid onset, faster elimination, right? Now, what is the, how it is metabolized? Metabolism. Metabolism. Again, liver. Liver metabolism. It is also metabolized in liver, right? Okay. Now guys, what are the uses? Same, nothing extra. Just one point I will write extra. Number 1, analgesia. Number 2, anesthesia. Number 1, analgesia. Number 2, anesthesia. And number 3, to blunt, since it has a very fast onset and a very fast offset, it is used for blunting the hemodynamic response of laryngoscopy. Blunts hemodynamic response of laryngoscopy. Okay, so this is our sufentanil. Sorry, alfentanil. This is our alfentanil. The next drug in this group, the last drug rather in this group, is remifentanil. Remifentanil. This drug has become very important. Why? Though in India it's not in clinical use, it is one of the most beautiful opioid derivative which we have. So what are the benefits of this drug? This is a pure selective mu agonist. So it is selective mu agonist, mu opioid agonist. Potency similar to fentanyl. Potency similar to fentanyl. So it is as fentanyl. So it is as potent as fentanyl. Alfentanil, the previous one which we discussed, was less potent than fentanyl, 1.5 to 110 times less potent. This is as potent as fentanyl, and it has taken the advantage of alfentanil being rapid in onset, like alfentanil. Alfentanil onset of action was how much? 1.4 minute. Similarly, remifentanil also has a very rapid onset. So blood-brain equilibration similar to alfentanil, the previous drug, whose major benefit was this only, the blood-brain equilibration, similar to alfentanil. Now, structure is unique. It has a unique structure. Structure is unique among other phenylpiperidine. It has a ester linkage. Ester linkage. Since the drug has ester linkage, it can undergo ester hydrolysis. Till now, all the opioids we have studied, morphine, ethidine, fentanyl, sufentanil, alfentanil, all are metabolized by liver. This drug has ester linkage, so it can undergo ester hydrolysis, that is metabolism independent of liver. Got it? So, metabolism by non-specific esterase, plasma and tissue esterase. Metabolism by non-specific plasma and tissue esterase. So, independent of liver for its metabolism. So, in liver dysfunction, kidney dysfunction, this may become this is a opioid of choice. Got it? So, what are the benefits? Precise, rapidly titrable effect. effect. Rapid onset and offset. Very fast onset and offset. No accumulation in the blood. Opioids prolong respiratory depression even after stopping them. But remifentanil, no accumulation. Onset fast, offset fast, and after offset, no effect. So, no accumulation. No accumulation. So, benefit is it has no accumulation. Right? Other properties similar to other opioids. Ventilatory depression. When we are giving it, there is ventilatory depression. Right? So, effect on respiratory system, same as other opioid, right? So this remifentanil is a boon. You know, it is metabolized by non-specific esterase. So it is very safe to be used in any liver kidney dysfunction, in neonates where liver kidney is immature. This is again an opioid of choice. So for liver analgesia also, this is opioid of choice. So uses analgesia. Beneficial in labor analgesia, since it can be metabolized in fetus also. Since it can be metabolized in fetus also. So there would not be a respiratory depressant effect if remifentanil crosses the placental barrier. Then beneficial as analgesic in liver dysfunction patient, in liver dysfunction, right? Beneficial in pediatric where liver and kidney function may be immature. So in all these conditions, the analgesic role of remifentanil is very good. The other use of remifentanil can be in anesthesia in a high dose. Like any other opioid, we can use it for anesthesia. So this is our remifentanil, a very interesting opioid, right, in this group. Okay, so these were our pure opioid agonist and most important opioid for the interest in, for anesthesia interest, right? There is one more drug I want to discuss, right? Tramadol. This tramadol is little different from other drugs. Tramadol is centrally acting partial agonist, not pure agonist, partial agonist on mu and kappa receptor, mu and kappa receptor, right? This drug is a racemic mixture. It is a racemic mixture of two enantiomers, right? It is a racemic mixture of two enantiomers. Both the enantiomers has different action. One is responsible for inhibition of non-adrenaline uptake, responsible for inhibition of norepinephrine uptake, and the other is responsible for inhibition of 5-hydroxytryptamine uptake. So both the enantiomer has a separate action. Normally, whenever a drug is enantiomer, it is said that it should be separated, the enantiomer should be separated. We have capability of separating and producing a pure drugs without mixture of two enantiomers. But in tramadol, separation would decrease its effect. Since it is racemic mixture and both the enantiomers have different action, its effect, tramadol analgesic effect and less respiratory depression effect, is responsible for it happens because of interaction of these two enantiomers, different action of these two enantiomers. So making tramadol as a pure drug would not be beneficial. So tramadol, what is the use? Analgesia, right? It is mostly used as analgesia in 50 to 100 milligram IV dose. The benefit is less respiratory depression, less nausea vomiting. Less respiratory depression, or rather not less, we should write. So it is used for analgesia, 50 to 100 milligram IV dose. No respiratory depression. No respiratory depression. And decreased nausea and vomiting. Nausea and vomiting. Okay. Guys, before finishing the opioid, there are so many other opioids also. Mostly we are using for analgesia. We are not using for anesthesia. The agonist, antagonist like buprenorphine, nalbuphine, pentagocin, they are used as for analgesia. So we have discussed the pure agonist, that is morphine, fentanyl and scungener. So majority of the opioids of our importance we have already discussed. Now other opioids, you just have to be familiar with their names and on which receptors they are acting, right? But just in case a question is asked, if a question is asked, 1 or 2 lines I would tell you about the other opioids also. The partial agonist and agonist antagonist one also, little points which can be asked in exam, right? So let us start with opioid agonist antagonist. Opioid agonist antagonist, in which the first drug, first of all, what is agonist antagonist? They bind to all the opioid receptor, and they have an agonist action on one and antagonist action on other. So most of the opioid agonist antagonist has an antagonist action on mu receptor and agonist action on kappa and delta receptor. So most of them have bind to mu receptor with either no response, no effect, or antagonist effect. Antagonist effect. Okay. And partial agonist on kappa and delta receptor. Partial agonist on kappa and delta receptor. So mostly they are antagonist on mu receptor and partial agonist on kappa and delta receptor. So first drug in this group, pentagocin. Pentagocin. Pentagocin, as we have already seen in the classification, the source, it's a benzomorphin derivative. Benzomorphin derivative. So classification, it's a partial agonist antagonist, and according to the source, it's a benzomorphin derivative. Now it attaches to the mu receptor, right? It attaches to the mu receptor but no effect on mu receptor, right? Or a weak antagonist effect. So on mu receptor, weak antagonist effect. Agonist on kappa and delta receptor. Agonist on kappa and delta receptor, right? It is used for analgesia, but since it is acting on kappa and delta receptor and not acting on mu receptor, so it cannot be used for a very intense analgesia, right? It's mostly used for analgesia, both like IV preparation also, oral preparation also. So for its uses are for analgesia. The dose range is 10 to 30 milligram IV or 50 milligram orally, right? The major demerit of this drug is that though it gives a analgesic effect, its major demerit is sedation, and since it is acting on delta receptor and kappa receptor, mostly delta receptor, so dysphoria or fear of death if a patient is on regular pentagocine intake. And other problem is it's a drug with a high risk of physical dependence. So side effects or problems: side effects, sedation, then fear of dysphoria or fear of death, and high physical dependence, right? So cannot be used very routinely in one particular patient. Then we have nalbuphine. It also belongs to the same group, agonist antagonist opioid, right? Bind to mu receptor as well as kappa and delta receptor, antagonist on mu receptor and agonist on kappa receptor, okay? And no effect on delta receptor. So dysphoria or fear of death would not be with nalbuphine. Actually, their effect depends upon their action on the various receptor. So it is again agonist, antagonist, binds to mu receptor and kappa and delta receptor, all three. Antagonist on mu receptor, and agonist on kappa receptor. So mostly it is agonist on kappa receptor, and its analgesic effect is because of its agonist effect on the kappa receptor, right? So again, what is the use? It's used for analgesia. Uses: analgesia, right? Analgesia. Then we have buterphenol. It is agonist on kappa receptor and antagonist on or partial agonist on mu receptors, ठीक है? Agonist on kappa receptor and partial agonist or antagonist on mu receptor, right? On mu receptor. This drug has one benefit, that it is very potent analgesic. It has a very high potency. So it is 5 to 8 times more potent than morphine. Actually, it binds to the receptor very avidly, very strongly. It has a very good binding capacity to the receptor, and the demerit is that this drug is only used as a parental drug. So it's only used for parental route, So it's only used from parenteral route, right? Again, what is the use? Analgesia. Uses analgesia. So its uses for analgesia, and since it is very potent, butyrophenol, and IV route is only available, so it's used as a very good supplement with anesthesia also. So adjuvant to other drug for anesthesia. So adjuvant to other drug for anesthesia. So it's butyrophenol. Now coming on a partial agonist. Partial agonist. Buprenorphine. Guys, buprenorphine is a thebaine derivative. Thebaine is a natural opioid. Thebaine derivative. And partial agonist on mu receptor. It is partial agonist on mu receptor. Again, it's a very potent analgesic. It is again more potent than morphine. It also has higher potency than morphine. So more potency, higher than morphine. The demerit, the pharmacokinetic, slow onset of action. Demerit, so pharmacokinetic, slow onset, right? Slow onset, highly lipophilic drug, so that's why it is more potent than morphine. But onset is pretty slow. Peak effect in 3 hours. Peak effect in 3 hours, right? So again, uses analgesia. All opioids, most important use for analgesia, right? And as adjuvant with anesthesia. Adjuvant with other agents for anesthesia, right? So this is a partial agonist. Now coming on opioid antagonist. We have few drugs which are very important for us in various conditions. Opioid antagonist. Now guys, this is very important. They are pure mu opioid receptor antagonist and no agonist action. So they are pure antagonist on all receptor, antagonist on all opioid receptor. We are not talking about a partial antagonist or agonist antagonist. We are talking about a pure antagonist. They are pure antagonist on all opioid receptors. Now there are 3 important drugs of our importance: naloxone, nalmefene, and what did I tell? Naloxone, nalmefene, and naltrexone. So now we are talking about pure opioid antagonist. Pure antagonist on all the opioid receptor. 3 important drugs for us: naloxone, nalmefene, and naltrexone. Let us now, first of all, I'll talk about all these 3 drug clinical uses. Now clinical uses. Number 1, to treat opioid-induced respiratory depression post-op. Treat opioid. Now I have given an overdose of opioid, or my patient is overtly sensitive to opioid, and post-op also there is a respiratory depression. So I can go for treatment of these drugs. So treat opioid-induced respiratory depression. Right, opioid-induced respiratory depression post-operatively. Right. Second, Second clinical use of this is to treat deliberate opioid overdose, opioid poisoning. Treat deliberate opioid overdose. Now, third important treatment in neonates. Mother has been given opioid during labor analgesia or during intra-op, during cesarean delivery, and fetus has a respiratory depression. So, to reverse the respiratory depression in neonates after delivery, right? So, treat opioid-induced depression of ventilation in neonate. It's used in neonate as well. Treat opioid-induced depression in neonate. Okay, so these are the most important clinical use of these three agents for us. Now, let us talk about first naloxone, the most important, the prototype in the group, naloxone. Naloxone has short duration of action, onset rapid onset, 1 to 2 minutes. Within 1 to 2 minutes, when you give it, within 1 to 2 minutes the action comes, and it has short duration of action. Short duration. It acts only for 30 to 45 minutes. 30 to 45 minutes. Okay. Dose of naloxone 1 to 4 microgram per kg per hour. This is the dose. Right? It's short acting, so infusion dose has to be given. Right? So this is the dose of naloxone which we are using. Okay. So what are side effects of most of the opioid antagonist is nausea and vomiting, because they also have a similar effect on CTJ center as opioid agonist. So side effects, nausea and vomiting. Side effect, nausea and vomiting. Now it has some other uses also, some novel uses. So other uses of this naloxone. It has been used in septic shock, septic and hemorrhagic shock. Some positive effects, septic and hemorrhagic shock. It increases blood pressure and heart rate. It has a sympathomimetic-like effect. So in refractory septic or hemorrhagic shock, some role of naloxone has been shown, though routinely it is not used. So it's used in alcoholic patient, alcoholic as the treatment for let's say treating patients who are alcohol dependent, right? Apnea in infants, post-op apnea in infants, though they have not been given opioid, naloxone has some role in treating post-op apnea in infants. So post-operative apnea in infants. So these are other uses of naloxone. Right? So we are using it in septic, hemorrhagic shock, alcoholic patients, post-operative apnea in infants whom we have not given opioids. Apart from treating opioid overdose, these are some other uses of naloxone. Now coming on nalmefene. Nalmefene is the only opioid antagonist which can be given orally and parenterally both. So oral and parenteral, both preparation, both routes. So it can be given by oral and parenteral, both routes. It's a pure opioid antagonist similar to naloxone and naltrexone, right? Greater preference for mu than delta and kappa receptor. So pure antagonist, long acting, more potent antagonist for mu receptor. More potent antagonist for mu receptor. It is antagonist on all receptor, but more potent on mu receptor. Then naltrexone also, same, naltrexone, right? Same. Again, bit longer acting. Naloxone is shortest acting, so long acting, right? Long acting. Again, it can also increase blood pressure. it also has a cardiovascular stimulating effect like naloxone. So it's also a long acting. So just you have to remember their names, and naloxone is the prototype of this group. Nalmefene is available as oral preparation. So this is about opioid antagonist. So these are the drugs which I wanted to discuss. Now, apart from giving the opioids parenterally, IV or orally, or as a transmucosal preparation, or as a transdermal patch, as we have discussed, fentanyl is given as fentanyl patch, transdermal patch. Opioid can also be given by another route, neuraxial route. So little bit I will talk about the neuraxial opioid. So let us talk about neuraxial opioid. What is this neuraxial opioid? Now, I have talked about neuraxial opioid even in our post-operative pain management when I was discussing the central neuraxial blockade in post-operative pain management. Here I will just tell you what is the mode of action of these neuraxial opioid. What do I mean by neuraxial opioid? This means placement of opioid in epidural or intrathecal space. Epidural or intrathecal space. This is called neuraxial opioid. Epidural or intrathecal space. We call it neuraxial opioid. Okay. Now, what do I mean by this neuraxial opioid? Okay. What is the mode of action of neuraxial opioid? We are not giving it IV. We are putting it in epidural or intrathecal space. This putting of opioid in epidural intrathecal space is based upon our knowledge of having a mu receptor on a nucleus of spinal cord, substantia gelatinosa nucleus. So it is based on this putting of neuraxial opioid is based on our knowledge of opioid receptor, mu. Opioid receptor, mostly mu receptor on substantia gelatinosa present on substantia gelatinosa of the spinal cord. This is a nucleus of spinal cord. This is a nucleus present on spinal cord. So there is a mu receptor on substantia gelatinosa nucleus of spinal cord, and our opioid act on this mu receptor, right? Now, what is the benefit of giving opioid in intrathecal space? It acts on the mu receptor present on substantia gelatinosa nucleus, provides a profound analgesia, plus apart from this profound analgesia, it has no effect on motor pathway and it has no effect on autonomic pathway. So the benefits are analgesia is not accompanied with sympathetic nervous system block and motor block. It is not accompanied with sympathetic nervous system block, motor block, or block of proprioception. Right. So there is neither sympathetic nervous system block, nor motor block, nor the block of proprioception. The only thing we are getting is analgesia. So it would not be accompanied with the side effects of local anesthetic placement in the epidural or intrathecal space, which is accompanied with sympathetic block and motor block, which we will discuss in the chapter of central neuraxial blockade. So opioid has the advantage over local anesthetic in putting it for analgesia in epidural or intrathecal space. Now, very important, how does it act? What is the pharmacokinetic? Opioids placed in epidural space can be absorbed, can be intravascularly absorbed. Opioid placed in epidural space can be intravascularly absorbed because there are very good venous plexus system in epidural space, can diffuse to spinal cord into CSF. It will diffuse to spinal cord into CSF, right? So it can be either intravascularly absorbed or it diffuses into spinal cord into CSF, right? So by both way it is acting. IV absorption also. So that's why the lipophilic ones are mostly intravascularly absorbed and the hydrophilic one are less intravascularly absorbed and more it diffuses to the spinal cord and act on the nucleus substantia gelatinosa present on the spinal cord, right? Now, though it is giving us the benefit of no sympathetic block, no motor block and no block of proprioception, there are some side effects of opioid. Side effects of opioids, neuraxial opioids. The first most important side effect is pruritus. Now, whenever pruritus is most common side effect, and it is because of the effect of opioid on a mu receptor present on trigeminal nucleus. So, acts on mu receptor on trigeminal nucleus. So it is not because of histamine release, it is because of it acts on mu receptor on trigeminal nucleus, right? Now the site is mostly around nose, neck and upper trunk. So site most common, nose, neck, upper trunk, thorax, right? And it is more commonly seen in pregnant ladies because of the simultaneous effect of estrogen also on these receptors. So more frequently seen in pregnancy, right? And this pruritus can be reversed by naloxone because it is acting on, because this is being this pruritus it is happening because of action on mu receptor, so it can be reversed by naloxone. Second, urinary retention. Urinary retention. So guys, urinary retention we can get even with epidural local anesthetic. The mechanism is different. Here we get a urinary retention because of again a opioid receptor present in the sacral part of the spinal cord. So acts on opioid receptor present on sacral spinal cord. Sacral spinal cord, right? This what happens that this causes parasympathetic block. It results in parasympathetic block, which leads to detrusor, relaxation of detrusor, and the capacity of holding urine increases. So what happens? That retention of urine results. So it's because of parasympathetic block mostly. Third most important complication, respiratory depression. Respiratory depression. Now respiratory depression caused by opioid are divided into two types. Early, which immediately happens after giving opioid and seen less, and the second one is late, which happens after 6 to 12 hours of giving opioid, right? So early and late. Okay, respiratory depression, and late one is mostly because of effect on respiratory center because of the migration of drug to the brainstem. Then fourth, sedation. So these are the 4 important side effects of neuraxial opioid. I am talking about neuraxial opioid in epidural or intrathecal space. Now all the opioids which doesn't have a preservative in it can be used in intrathecal space. Remifentanil has a preservative with it, so it cannot be used for intrathecal use, right? Only the opioids which we are using for epidural. For epidural, we are using morphine, more commonly, fentanyl, alfentanil, sufentanil. All these we are using. Even pethidine is also used, right? And for intrathecal, we can use morphine, fentanyl, right? Mostly these 2 are being used more commonly, right? So epidural and intrathecal, we are using opioid, that's called neuraxial opioid. Okay, this is all about neuraxial opioid. Before finishing off opioid, one term I want to make you familiar with, that is neurolept analgesia or neurolept anesthesia. Neurolept analgesia or neurolept anesthesia. Okay, this term, this neurolept analgesia or anesthesia, this was coined by De Castro or Mundeleer. This term was coined by De Castro and Mundeleer. Okay, this is a technique in which we combine the major tranquilizer, butriphenol, that is droperidol, right? Usually a butriphenol like droperidol, and a potent opioid analgesic, mostly fentanyl, to produce a detached state of the body. The person is detached in a pain-free state, immobile, right? This is what is called neurolept analgesia. What do we do in this? This involves combining a major tranquilizer, right, butriphenol, mostly droperidol, with a potent opioid, mostly fentanyl. So this involves combining a major tranquilizer, droperidol, with a potent opioid, fentanyl, right? So what does it produces? It produces detached, pain-free state, right, of immobilization, right? What is the characteristic of neurolept analgesia? Analgesia, absence of clinically apparent motor activity. So what are the characteristics? Analgesia, then lack of apparent motor activity, suppression of reflex, autonomic reflex, abolition, no, suppression, yes, suppression of autonomic reflex and cardiovascular stability. Fifth, amnesia. Amnesia. Right, it also provides an amnesia. So it is providing us with analgesia, lack of apparent motor activity. Patient can move, but patient is in an immobile-like state, detached state. Suppression, not abolition of autonomic reflexes, cardiovascular stability, and amnesia. Right, and we can call it neuroleptic anesthesia if we add nitrous oxide to it. Neuroleptic anesthesia, addition of inhalational agent in the group. Inhalational agent, most commonly nitrous oxide. Okay, so this is neuroleptic anesthesia. Neuroleptic analgesia we discussed. This is neuroleptic anesthesia. So this is all about opioid which I wanted to discuss. This finishes our opioid. Okay, thank you.